This lecture is going to be on maldigestion and malabsorption. Maldigestion is a failure to break down ingested food into smaller substances that can be absorbed by the intestines. In dogs, maldigestion is primarily due to failure of the pancreas to produce digestive enzymes, and this occurs with loss of greater than 90% of acinar cells. Exocrine pancreatic insufficiency, or EPI, may occur secondary to pancreatic atrophy or chronic pancreatitis. EPI is most commonly seen in German Shepherd dogs, and it causes clinical signs of weight loss despite a vigorous appetite. Clinical pathologic abnormalities are typically not apparent on routine testing. This includes unremarkable CBCs, chemistry panels, and urinalyses. So, a clinical suspicion is based on historical and clinical findings. Serum TLI is the best test to diagnose EPI, and this test was discussed in the previous lecture. Malabsorption is a failure of the intestines to uptake appropriately digested substances. Malabsorption is therefore a result of primary intestinal disease. However, malabsorption may be secondary to a variety of intestinal disorders, and it does not distinguish the cause of the intestinal disease. Unlike maldigestion, malabsorption can cause changes on screening tests. So if the intestinal disease results in hemorrhage, so hemorrhagic ulcers, then you can see decreases in total protein and a regenerative anemia. Also, protein loss may occur without anemia. Lymphocytes can be lost with lymphangiectasia and loss of lymphocyte-rich lymph. Also, cholesterol can be lost with lymphangiectasia as well. If the intestinal disease is diffuse enough, then there can be decreased absorption of calcium and hypocalcemia. The secondary tests for malabsorption include serum cobalamin and folate, as well as plasma turbidity test. This diagram represents normal cobalamin and folate intake. Cobalamin is absorbed in the diet, and once it enters the intestine, it is protected by a protein called intrinsic factor, which is excreted by the pancreas. This binding of cobalamin to intrinsic factor occurs in the presence of a cofactor, which is bicarbonate. Intrinsic factor then protects cobalamin from bacterial digestion, and the cobalamin moves down the intestines and is eventually absorbed at the ileum. Some of cobalamin does not bind intrinsic factor, or it spontaneously unbinds intrinsic factor, in which case the cobalamin can then be consumed by the bacteria and converted to folate. And this folate that's produced by the bacteria, as well as dietary folate, can be absorbed by the duodenum. Both folate and cobalamin are both essential for DNA synthesis within a variety of cells. With exocrine pancreatic insufficiency, the pancreas is not producing enough intrinsic factor. It's not producing enough bicarbonate, so cobalamin does not bind intrinsic factor, and it's not protected from bacterial consumption. So, a lot of the cobalamin is consumed by the bacteria and the bacteria produce an abundant amount of folate. This causes an increase in folate in blood and a decrease in cobalamin. TLI and PLI are also not produced in sufficient quantities, so you can see decreases in these substances in blood. Small intestinal bacterial overgrowth is when there is a lot of bacteria in the intestines. And this bacteria essentially consumes cobalamin. It either consumes it before it binds intrinsic factor, or it consumes cobalamin and steals it from cobalamin factor, or from intrinsic factor. So all of this cobalamin is consumed and increase conversion to folate, and therefore increase folate in blood. This also causes decreased cobalamin in blood. TLI and PLI should be normal. Duodenal malabsorption is when the intestine of the duodenum is diseased. So there's decreased absorption of folate, but cobalamin is unaffected. Ileal malabsorption is when the enterocytes of the ileum are diseased. So there's decreased absorption of cobalamin, decreased serum cobalamin concentration, but folate concentration is unaffected. Diffuse small intestinal disease is when both the duodenum and the ileum are diseased. Therefore, there's decreased absorption of folate, decreased absorption of cobalamin. So here is a table of what can increase and decrease serum cobalamin and folate concentrations. Both EPI and small intestinal bacterial overgrowth can cause decreased cobalamin and increased folate. You would differentiate these based on a TLI test, which would be decreased for EPI. Most common diseases that can alter cobalamin and folate concentrations are ileal disease and duodenal disease. The plasma turbidity test is a test of fat digestion and absorption. In any animal, whether they are healthy or have mild digestion or malabsorption, the plasma of a fasted animal should be clear, meaning that the sample does not have a high level of triglycerides. If a normal animal ingests a fatty meal, whether it is non-digested fats or pre-digested fats, then those fats are absorbed, enter the blood, and the plasma appears lipemic. An animal with maldigestion cannot absorb undigested fats, so the plasma after absorption of or after ingestion of a fatty meal would appear clear. However, if those fats are pre-digested before the animal intakes it, then the plasma will appear lipemic because the pre-digested fats can be absorbed. Animals with malabsorption cannot absorb fats whether they are undigested or pre-digested. So plasma for dogs or animals with malabsorption will be clear in any instance.